So let's talk about diabetes insipidus versus SIADH. This topic is super high yield now, especially now because we've got case studies. And the thing about case studies is they love to compare and contrast two different diagnoses. So, for instance, diabetes insipidus having no ADH, whereas SIADH, we have too much ADH. So they can have similar and or completely different signs and symptoms, but they both fall under endocrine. So the first one we're going to talk about is diabetes insipidus. Diabetes insipidus. In diabetes insipidus, we have no ADH. No ADH. Well, what is ADH? Let's start from the beginning. ADH is anti-diuretic hormone. So let's just take a step back and understand what ADH is. Anti-diuretic hormone means I'm not going to diurese. I'm not going to diurese, anti-diuretic hormone. Or I'm not going to pee. It's a hormone that's going to not allow me to pee. ADH is anti-peeing, no peeing hormone, anti-diuretic hormone. In this situation, I don't have this hormone. So it's kind of like a double negative. So let's just do this. Let's take it a step further and let's just do a double negative. So if I have a double negative, these cross each other out. So guess what? All I do is pee. So you see, you take it one step back and you're like, okay, well, anti-diuretic hormone means that hormone is going to stop me from peeing. If I say I have no anti-diuretic hormone, it's just a double negative. And now all I do is pee, which is where we get the two P's of DI, of diabetes insipidus, which is polydipsia, polyuria. I like to think of it the other way around. Polyuria, meaning all I'm doing is peeing because I have no antidiuretic hormone. So if I'm peeing, am I not naturally going to become thirsty? So if I'm peeing excessively or urinating excessively, I'm going to have this intense thirst. So we've got this polyuria and this polydipsia. So what are some causes? Well, we've got lithium, family history, encephalopathy, trauma to the brain, surgery, brain tumors, head injury. A lot of it has to do with the brain. We've got lung disease. But ultimately, the causes aren't what the boards are after. Now, maybe as a side effect of lithium, sure, I'll take that. But ultimately, the signs and symptoms are what they're going to want to look at. Because if you think about it, the signs and symptoms of polyuria, polydipsia are going to actually correlate with one of the most high yield topics that we cover everywhere, which is in fact dehydration. Why is dehydration so important? Well, let's think about this. In cardio, diuretics, sure, okay. How about in maternity? Morning sickness, hyperemesis gravidarum? Sure. How about GI? Pyloric stenosis? Yeah. How about gastroenteritis? Yeah. How about diarrhea? Or how about something like lactulose, which is just a laxative? Dehydration. Now we're in endocrine. We're talking about dehydration with polyuria. So, and that's just scratching the surface of all the different ways I can ask dehydration. So if you really want to understand a topic that's going to show up on your boards in some way, shape, or form, know dehydration. Know it. And now I take dehydration on a couple of different levels. First and foremost, we look at the signs and symptoms of someone. We look at them. So How about low urine output? Okay. How about skin tenting? Sure. How about dry mucous membranes? Yeah. Decreased tears? Sure. Dry skin? Okay. How about in infants or in children? Decreased wet diapers, sunken fontanelle, no tears. So you see, there's so many different ways that I can ask the tachycardia, hypotension. So you look at all the signs and symptoms that I can clinically look at, and then I take it a step further, and now I start to look at the concentration of my serum or my blood and the concentration of my urine or my serum osmolality and my urine osmolality. So let's start with the blood. Let's start with serum. What does serum osmolality mean? Well, that always kind of got to me. Serum osmolality, serum, blood, osmolality, concentration. So now I ask you this question. In diabetes insipidus, all I'm doing is peeing, peeing, peeing. I'm trying to replenish it. I've got this intense thirst, but am I catching up with how much I'm peeing out? Probably not. So I'm peeing, 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 which means that my fluid, my serum is lacking fluid. My serum, my blood is becoming thick and viscous because I'm peeing everything out. So everything tends to become more concentrated. So if my blood concentration goes up, my serum osmolality, interchangeable terms, has also gone up. So I have an elevated serum osmolality. How am I going to test for that? Well, why don't I look at the hemoglobin and hematocrit? If my blood doesn't have the water because I'm peeing it out, the blood is going to be thicker, which means, relatively speaking, my hemoglobin, my hematocrit are going to be higher. I don't have the water to dilute it. My red blood cells are going to look elevated compared to if I had fluid to dilute it. So again, looking at the serum, we're able to determine the osmolality, the concentration being elevated. We look at the H&H, the hemoglobin hematocrit. We look at the red blood cells. We're like, whoa, all right, cool. We take it a step further and we look at the urine osmolality. Well, in this situation, we have determined that all I'm doing is peeing. All I'm doing is peeing. If I'm peeing, 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 is my urine going to be concentrated or dilute? If I'm peeing everything out, my urine's going to be dilute. All the fluid is coming out of me, which means that all the particles in my urine are going to be dilute because it's combined with a bunch of water that I'm peeing out. So my urine concentration is low. It's dilute. It's not concentrated. So I have a low urine osmolality. A low urine osmolality. Well, if my urine is concentrated, and those that don't know my background, well, I was an MA, a medical assistant, before I went to med school, right? So I used to grab that little cup of urine specimen from the little metal cabinet that was connected to the bathroom. And anybody that's ever experienced doing a urine dipstick or urine analysis, you open it up for a concentrated urine, you're going to look at it and it's tea colored, cola colored. Maybe their amount, the volume is limited. And now you open it and whoa, you get a whiff of it and it's got this pungent, potent smell. Because the urine is concentrated. So I've just given you signs and symptoms of urine being concentrated versus urine being dilute, where it would look the opposite. So in this situation, we're peeing. So now, is it going to be minimal amount? No, it's going to be a lot. In this situation, is it going to be a dark tea colored or cola colored urine specimen? No, it's actually going to be clear or close to it, because all I'm doing is peeing. Think about it. When you drink a lot of water, and you have to pee it out, well, you're peeing out a lot. The volume is there. And when you pee it out, is it a darker color or is it actually clear? It's clearer. So in this situation, because we're peeing so much, it's going to be dilute. Larger volume, clearer substance, probably no smell, or not a pungent smell like you would with concentrated urine, because we have low urine concentration, low urine osmolality. Which means in that specimen that we've got where the person is peeing out a lot and it's dilute, we've got a situation where we have to look at how gravity works on the particles in the urine. And that is specific gravity. If something is dilute, is gravity going to work on it hard? No. If something is concentrated, boom, gravity works on it harder. Which means that in a dilute urine, the particles are all spread out. So gravity is not going to work on it as hard as if they were all together, and then boom, gravity works on all the particles at once. So in this situation, we have a low specific gravity, a low specific gravity. So what do we do about it? Well, the first thing is obviously going to be treat the underlying cause. Autoimmune disease, immunosuppressants, family history, not really much we can do about it. Traumatic brain injury or any type of tumor, remove it or treat the underlying cause. Lithium, slow down or hold, change the medication. The idea would be to treat the underlying cause. That'd be the solution. The resolution would be as such. But ultimately, give them what they don't have. It's a concept that I say throughout medicine. Give them what they don't have. In this situation, they don't have ADH. So what do we give them? Give them ADH. And ADH is going to be desmopressin.